So that's a Gait lab, essentially. You've got the fella there markered up with EMG electrodes. He does have reflective markers on. The two black squares in the floor are force plates, and you can't really see the motion capture cameras there up above. We did actually, it won't benefit any of you by the time it gets funded, but we put in a budget for an actual biomechanics lab with motion capture, force plates, and we would integrate the present EMG system, but it requires infrastructure change, which means knocking down walls and raising ceilings, which is quite expensive, and equipment that's totally close to $200,000. So I don't know that that'll get funded or not.
You can fund that.
It looks good on paper.
Like 2 people going through PT school is fine.
I'm just trying to get a new bench in the men's locker room.
We are not, as faculty, seeing this money that you're providing. It goes to pharmacy, it goes to that nice building up the street with the fancy chairs and the desks and so on.
That's for shit.
It is. Can we complain? Can we get our own building yet?
I just want a bench in the men's locker room. That's all I want.
Or at least, maybe like a parking garage.
We got a letter yesterday that our tuition's like $1,014 next semester.
Awesome.
Went up. They're like due to increasing your student experience or whatever.
I'm still waiting on a free t-shirt at least.
Okay.
You haven't gotten any free stuff yet? Well, you get the...
Yeah, we got that half a sandwich that one day.
That half a sandwich.
There's another one of those
Everybody
coming
gets
up,
some
isn't
before
there?
you go up for the other half of your sandwich.
That was the only free thing.
You'll eventually get through it.
Oh, right.
Then when you're making 7 figures, you can give back when they send you requests for alumni donations every 4 months.
Yeah.
I'll make
I'll
second
figure
figure.
say about that.
I did the following.
Every 2 weeks to make a donation.
All right, terminology, mechanics. So when we're looking at mechanics, this is the interaction of forces, motions, deformations, and flow. You don't need to worry about flow or deformation. But motions we are doing, that's our free body diagrams, and our interaction of forces, which are our free body diagrams. Kinematics is movement, right? Position, velocity, acceleration, all things surrounding movement. And kinetics is force. Remember that. Okay, forward dynamics. Forward dynamics is estimation. Okay, when we look at, for example, upper body movement, we're using forward dynamics to determine what's going on. So throwing mechanics. You bring in baseball throwers, capture their movement, have EMG electrodes on, and all the stuff that you can get in a lab. We do not get direct measurements. We use forward dynamics to estimate what's going on at the shoulder, elbow, and wrist. For lower body, we use inverse dynamics. Inverse meaning what? Inverse, the reverse, bottom up instead of top down, or top down versus bottom up. We have the ground foot interaction where that initiates our ground reaction force. We can measure that with the force plates. We can combine that with our movement analysis and the measurements we get from that, and we can calculate joint moments of force and other components such as joint torque and muscle action. So make sure you remember the difference between inverse and forward dynamics. Components of kinematics, center of mass. These are determinants of gait. If our center of mass is off, is our gait normal? No. Okay. Kinematics, we're looking at that movement component, sagittal, frontal, transverse plane, and other. You guys don't need to worry about other or, for that matter, transverse plane. It's very hard to see. Kinetics, again, the forces, you're looking at ground reaction force, center of pressure. Center of pressure is where that ground reaction force is presenting relative to the foot. Ground reaction force vector method, that's what we're doing with our free body diagrams. And we're estimating joint moments, inverse dynamics, and the muscle torque, sagittal plane, and frontal plane we can do as well. Center of mass. Bipedal trade-off mobility versus efficiency. What's bipedal?
2 feet.
2 feet versus, say, an animal that's 4-legged. What's the difference? Who's more efficient? An animal on 4 legs or a human on 2 legs?
Let's say an animal,
Okay, why?
because they don't have to, like, there's less stress on each.
Why is there less stress?
Because
Think
they
of
keep
that center of mass.
distributed.
When you're walking down the hallway, if your center of mass, say, is somewhere in your trunk, abdomen, what's it doing? As you walk each step, is it going up and down? Or is it walking in a straight, or moving in a straight line?
Straight line.
Up and down.
It's going up and down. With every step, you piston it up and down. An animal on 4 legs, it's almost a perfectly straight line, even when they're running. So the advantage is we can free our arms, hands, elevate our heads, see where we're going, and we can move on challenging terrain. 4-legged, it's still better all around. You're more efficient. Disadvantage, very hard to move in a straight line. It's more like a wheel where you're going around and around. It's not a huge pistoning effect, but you are going up and down. And it's an arc-shaped pattern, and when we walk, you'll see, when you start doing the analysis, you'll see we wobble side to side. So maintaining smoother trajectory of the center of mass is determinant of how we walk. So when we look at the different phases, and we're going to be doing some of this today, we'll look at each of you walk and see who's the most screwed up and pick on you.
Probably me.
Okay? Admitting it's the first step. All right. Stance, initial contact. Again, fairly common sense with most of these terms. Leading extremity touches the ground. Heel strike or heel contact, initial contact are the terms. Abnormally, we may see the whole foot contact the ground or the toe first. Who does that?
Toe
First, do that when you're sprinting.
Well, the high heel thing actually for the week after next, the ladies will be, ideally if you have them, bringing in some form of high heel so we can look at that.
6-inch stilettos, ladies.
Or Casper if you have them. We don't judge. And then when we do the force plate labs, we'll be looking at different footwear on the force plates.
Do toddlers do the toe walk?
Depends. I don't know. I don't think I've ever even seen a toddler walk. I'd have to think about that. Little kids, I see they toe walk, but they have tight hamstrings and or early low-grade CP, and they start doing it. And the younger ones, if it's bad enough, they go in and nick the Achilles tendon to release it, and then they walk normally. Foot flat, so that's where the foot goes flat after initial contact. Mid-stance, weight of the body is over the supporting lower extremity. Heel off is heel off, and toe off is toe off. The key is to figure out where you are in the cycle and where you're seeing abnormality, which we'll go through that. So sub-phases, you've got heel strike phase, mid-stance phase, and push-off phase. You need to be familiar with all the different phases because that will be questioned. So heel strike, initial contact, foot flat to heel off for mid-stance, and heel off to toe off for push-off. So when we're looking at swing phase, we have early, mid, and late. Toe off ground to the mid-swing or when the extremity is directly under the body. That's the end of the swing phase, leading into mid-swing where the extremity is underneath the body. Late swing is where you're preparing for heel strike. What has to happen there that people get into trouble with? Say it louder.
Dorsiflexion of your foot,
Okay, why do we need that?
so you don't have like a foot drop.
Clear the toes out of the
You
way.
clear your toes so you don't drag the foot, trip, stumble. It's a very common presentation, especially with degenerative joint disc disease and disc herniations, as well as various neuropathies. So these several graphs I give you, you don't really need to be concerned about the percentages. It's more giving you a view of what's happening at each point, where we see right swing, right stance, left swing, left stance, single leg and double leg support. What's double support?
Standing?
It can be, but during gait, what is it?
It's where you got toe off and toe off and heel strike.
Toe off,
So like that.
Or
meaning
right mid stance.
is one leg in contact with the ground or both legs?
Both.
Okay. What happens with the faster we move? Does that time frame in double support shrink or get bigger?
It shrinks.
It shrinks almost to at a full sprint. You don't have double support. You are essentially only single support and you're springing yourself forward with each leg.
Airborne.
When you're running, you don't want ground contact.
You don't,
Like if, when you're sprinting, you just want the least amount of ground contact.
yes, you do want ground contact
Well,
though.
yeah, you want it,
Unless
but
you're
you
like
don't
the
want
cartoon
much.
guys that just spin their legs and shoot off.
Scooby-Doo.
All right, so view prior slides for phases. Again, if walking speed increases, the time spent in each phase decreases. And that's where you see problems. What do people with gait abnormalities do? Do they speed up or slow down?
Slow down.
They slow down, and that does what in terms of support?
Makes them,
If double support increases the slower you go, is one leg of support more or less balanced than two legs of support?
less balanced.
It's less balanced, so
If it was more, I would have already done.
people who have a gait or abnormality, you can easily identify that by the fact that they go slow. They start walking slower with every component that they're using, so that they're spending more time in double support and preventing themselves from falling. Again, another graph looking at the phases, heel strike, mid-stance, push-off. Be familiar with these and be able to interact with them with questions. Early, mid, late swing. When we're looking at specific variables, if you do true gait analysis, which personally I don't find all that thrilling, unless there's some orthopedic variable linked to it. But when we're looking at temporal variables, what's temporal?
Time.
Time. So stance time, time spent in stance. Single support, time spent in one leg being on the ground. Double support time, two legs on the ground. Step duration, time to complete one stride. Remember, that's not one step, it's one stride, which is different than a step. And cadence is the number of steps per unit time. So when we looked at the variables, we're looking at the stride length. This is the linear distance between two successive events for the same lower extremity. So one heel strike to the next heel strike for the same leg, not right and left, just one leg. So a normal stride is 2 steps, right and left, and it varies. Everyone here is going to be different. Every person you look at is different. Whereas step length is now the distance between opposite limbs and a successive event. So heel strike of one to heel strike of another. Step width is the distance between one foot and the other. So where might that come into play? Is a nice narrow support more balanced, or is this more balanced? So again, you can easily pick up gait abnormality or balance dysfunction by looking at someone and seeing how far apart their feet are and whether that's a component of their pathology. Degree toe out, angle of foot placement. So this is the people who walk way toed out. You're seeing a much larger degree versus a normal toe out, which is variable. Some people are naturally toed out slightly, others are a straight line. Yeah.
So when we're talking about like varus valgus deformity and hip dysplasia, is this something that presents all the time?
This is normal. Degree toe out, there's a certain degree, but when you have anteversion, retroversion of the tibia femur, you may end up with a greater degree of toe out pathologically.
Is there any time that like people are toed in that's
Sure.
not
That's usually deformity.
okay?
Yeah. When you look at pronation, supination, people who are pronated, they naturally toe out, and they do that to compensate for the foot falling inward. Is anybody here pronated and wears orthotics? No? Anybody lying because they don't want to be an example?
Take your shoes off.
No.
All right, so there's your toe out, which again can be normal. It's perfectly acceptable to have a certain degree toe out. You will notice it. These things stick out when you see these folks. If you are looking at somebody in shorts and they're walking at you and away from you, you can clearly tell whether their femur is turned in, turned out. Hello, Jessica.
Sorry.
What's your excuse?
I don't have one.
Okay. That's okay. Okay. So degree, how much they're turned in at the femurs, turned out at the femurs, tibia turned in, turned out, and whether that's presenting. Usually it's obvious. You just have to discern based on other factors such as age, whether it's an osteoarthritic problem or whether it's a rotational congenital problem.
You see a lot of people with the bilateral discrepancy as well too, like one might be toed out normally, but a lot of other, the other side is excessively toed
Usually
out.
we tend to be symmetric. So if it's congenital, it's bilateral. Usually if it's one-sided, they broke something and it didn't set correctly or the surgery was done improperly. Observational gait, which is an aside to that does happen. Okay, I've seen intermedullary rod placement for femur fractures and tibia fractures on video in foreign countries that was absolutely, it looked like a butcher did the work. And then when you see it done in the US, Canada, or in more modern countries, it's done through pristine little incisions with fluoroscopy and perfect placement. And then you see these big gnarly incisions and rods that are crooked, and it's, stuff happens. So don't have your femur fixated in India or any place like that.
But it's cheaper.
It is. 3 cows and a bag of flour and you're done. Observational gait. So the observer is making the judgment as to whether things are abnormal. Is this anecdotal? Is this objective?
Yeah.
What do you think it is? Jessica?
Objective?
It can be. Explain why. I'm just picking on you
I
now.
know. Everybody's different? I don't know.
Well, objective, but if we're making the judgment, are judgments objective?
Yes.
Are they?
They're more subjective, but
It's subjective, but is it objective within your sphere of clinical
Yeah.
experience? Yes. So as a clinician, you're making that clinical decision. So technically it is an objective component, but are all of you going to come up with the same conclusion about a gait analysis? No. So it's not truly objective. It's only within your own little bubble of experience that it is. So this is what we do without a gait analysis lab or biomechanics lab. And again, it's not the end-all be-all. Nobody's going to call you up and say, look at this gait and tell me what you think. When you see true gait analysis, how many are familiar with the Shriners Hospital? One. So Shriners Hospital is for sick kids. There's one in Erie, Pennsylvania, and they have a staff of like 8 to 10 biomechanists that runs the Biomechanics Lab. All the little kids come in. They do, every one of them gets a gait analysis with motion capture, force plates, and everything. That gait analysis goes to the surgeons and the physiologists and the other clinicians, physical therapists included, and they assess what would be the most appropriate plan of action for the little kid with the abnormal gait, whether it's tendon release or reconstruction or whatever it may be. They do it on everyone. Unless you work in that type of setting, you're just going to use your eyeball. Okay, you're not going to have the time, money, or inclination to do full assessments like that. So when we're looking at an actual gait analysis, we're looking at planes of motion. For you, frontal and sagittal, how would we look at transverse? Can we look at transverse? You can eyeball it to a degree, but you can't really do that just watching somebody walk back and forth, unless you had like mirrors on the ceiling and you were walking along with them. It's hard to do. So we really don't worry about it. You can infer transverse plane motion from what you get from sagittal and frontal. Pelvis, femur, tibia, foot, that's what we're looking at. And the trunk, obviously. The trunk is going to determine a lot, but when we're looking at alignment, we're looking at the pelvis down. You're looking for abnormalities. Whatever your preference, if you want to work from the top down or the bottom up, that's your call. I vary depending on who I'm looking at. If it's something where it's clearly a lower leg issue, I'll go from the bottom up and describe it, or if I don't know what's going on, I'll just start at the head and work down and give a sentence or two about each component. Shoes, sneakers, barefoot. What's probably the most appropriate? Barefoot. But if the person tells you it only hurts when I'm at work wearing my shoes, you want to see what's going on with their shoes. So step one, choose your path for analyses, where the person will walk. That sounds like I'm being sort of facetious, yes, but it's not, okay? If you have a clinic somewhere, you need a pathway. Think about that and look where you will want them to walk. Also, is it the case where they're having problems on uneven terrain? They only hurt when they're out walking in the park. Do you want to take them outside and do this? Yes. Choose the plane of motion, so you got to look from the front and the side, and footwear. So top down or bottom up, and you're looking for any asymmetries. Some of you will be much more efficient at this than others. Some of you will be nitpicky and be able to say, well, that's off, that's off. You know, these are the people who correct pictures when they walk by. If you do that, you will be good at this. I stopped correcting. I just note that they're crooked. Doctor says
So you
it's
just
good
leave
for
like
me.
a sticky note on the picture frame and be like, fix that later.
This is off. Stick. Keep writing. No, I don't do that anymore. So if asymmetry is noted, assess the effect above and below. So do you see something at the knee? In which case, look above at the pelvis and see if it's affecting the pelvis, or below at the foot and see if it's affecting the foot. The vast majority of the time, it's going to be overpronation that's affecting the knee and the hip going from the bottom up. So the asymmetries and their effect lead you to what you're identifying as a pathology. Sagittal plane, in the trunk, you're looking for anterior-posterior positioning. Observe head position. What's that tell us?
Head position?
So if James is standing here like this, and he's hunched forward because his back hurts, and he can't straighten up, what's this telling us about his gait? What did we talk about early today when I said center of mass? His center of mass is forward, which is going to change all of the mechanics below. But what else might be happening with that?
He'll be walking on his toes more.
He'd be shifted forward. He will change the pattern of his phases of gait, heel, strike to toe off. Kind of looks like the water boy there. What about the...
Can I sit or?
Yes, you may sit. Billy, Bobby Boucher. Your medulla oblongata is okay. Pelvis, look for orientation of the anterior-posterior line of progression. So, pelvis, is it tipped in the front, or is it tipped in the back? Is the pelvis rotated, anterior-posterior neutral? Trunk position can play a role in this. If your trunk is tipped forward, which way does your pelvis go? Common sense-wise. Is it going to go forward with you?
Rotates anterior, yeah.
Yeah. And if you're leaned back, it's going to rotate back. I did have a patient, the only one I've ever seen, who was leaned back. We never quite figured out what was wrong with her. She didn't know what was wrong with her. All the physicians didn't know what was wrong with her. She was about 5'6" or so, morbidly obese, and she had multi-joint osteoarthritis, knees and hips all had to be replaced. But she would walk by tipping her pelvis back. She would turn her legs out, and she used a cane, and she walked like this. And we could never figure out why she did that. She was essentially resting on her Y ligaments in her pelvis, her hips, and creating a pivot point at that section. She had the knees replaced, and the thought was, well, maybe that'll fix her. It didn't. She just had less pain with the same gait pattern. So you may see somebody leaning back. Most often it's leaning forward. So pelvis anteriorly rotated. Everybody stand up. This was an issue last year with the second years, where they all griped when they got it wrong on their test. So if you push your pelvis anteriorly, what does your back do?
Arch extension.
If it goes into extension, that's what? Lordosis or kyphosis? Lordosis. If you flatten the low back, or I'm sorry, if you posteriorly rotate the pelvis, what does that do to the low back? Kyphosis or flattening, okay? Everybody got it?
Yeah.
Everybody's going to get it right? Yes. So chest thorax will sit forward, leading the progression with an anteriorly rotated pelvis. Posteriorly rotated pelvis, we're going to see decreased lordosis, chest thorax neutral. If this is, what, my yardstick? If this is your pelvis, there's anterior, there's posterior. If this muscle group, what's this muscle group that's going to pull up on the pelvis?
Hip flexors.
Hip flexors pull up. Here's your head up here.
I was gonna say, so
Is it glute? That's the,
So-
that's the front.
Anterior,
Oh,
posterior.
that's my glute.
What's going to pull up on this pelvis?
Psoas. Oh, rectus, yeah.
Abs are going to pull up. That does what to the pelvis? Is it an anterior or posterior rotation?
Posterior rotation.
Posterior. What's going to pull down?
Glute.
No.
Flex.
We're anterior.
What's gonna pull
I
down?
don't know the front and the back.
You said it before.
Me? Oh,
No.
I was like, I know. It's
me?
glute.
Yes.
So it's, oh, the hip flex.
Yes. The flexors connecting up on the pelvis can pull down. What's that rotation? Anterior or posterior?
That's anterior rotation.
Anterior. How about posterior? Ellie, posterior now.
You know this
We're in
one.
the back.
You just said it.
What pulls up on the pelvis?
I think it's just glutes, not glute med.
It'd be sacrospinalis muscles.
It could be the paraspinals or anything that's going to lift up or push your butt back. How about downward?
Hamstrings.
Hamstrings.
Yes, I was thinking.
What?
Is that hammies?
Hamstrings?
I was
Yes.
thinking that too.
So there's a picture in here of this. Be able to work with that and tell which way the pelvis is going.
Oh, it's right here, guys.
That should, is everybody clear with that? So for pulling upwards anteriorly, we posteriorly rotate. We pull downwards anteriorly, we anteriorly rotate. But we'll go to this picture. Maybe this will help.
I know we just did it. That makes more sense.
Everybody look. Everybody read. Make sure this makes sense. If not, we will go through it again, step by step.
That makes more sense.
So all of you will be able to determine which direction the pelvis is going in the sagittal plane by a muscle group I give or a description. You can tell what muscle is activated.
Hopefully.
Okay. This will become second nature to you. It will make perfect sense looking at anterior posterior. Who walks around with more lordosis, males or females? Females. Females,
Butt sticking out.
I wasn't going to say that, but
Call it the Donald Trump
yes.
butt.
So when you see that, what structures might be involved or irritated? Somebody who comes in with lumbar, pelvis pain, leg pain, and you see that they're walking around with a gigantic lordosis, so as tightness may be present, weakness of erectus, which creates muscle imbalances. So if somebody is in their 40s, 50s, and has been walking around lordosed their entire life, they're going to have weak abdominals, probably a tight psoas. What about the hamstrings? Weak or lengthened and tight.
I was gonna say, what did it take?
Well, over that duration, they might have just become dysfunctional. All right, so anterior tilt, I changed this. What's in your notes, change it to this, because that resulted in tremendous confusion last year. So cross out what's there and put what I put for hamstrings. So when we anteriorly tilt the pelvis, the hamstrings are pulled into tension. It's not contractile tension. Does everyone grasp that? You're just lengthening it. You're making the distance from attachment to attachment longer. So they can be tighter, lengthened, whatever adjective you want to use to explain that. So tibial excursion may decrease anteriorly. Somebody explain that to me.
Say that again.
Decreased tibial excursion anteriorly. What's excursion?
I don't know.
Travel, motion, duration of motion. So if you're walking and you go from toe off, you need to swing your leg through to get to heel strike, right? So if your hamstrings are tighter or lengthened due to this chronic anteriorly tilted pelvis, are you going to get the same travel out of the tibia when you're going into your final approach for heel strike? No, because the hamstrings are limiting it. This is very common with patellofemoral pain syndrome, which is what PFPS is. So when that happens, that's something to look at. Can you stretch the hamstrings? Yes. Can you try and correct the pelvis? Yes. Which is going to be more efficient in 10 to 20 physical therapy visits?
No, handies.
Hamstrings. Because they're 40, 50 years old, they've been walking around like this for the whole time. You're not going to correct that in 10 visits at an hour a visit.
What do you mean, like, you wouldn't be able to work on other muscles?
You can work on it, but are they going to go from their rear end sticking out for 40 years to a perfectly nice straight position?
No.
No. The more efficient path is going to be to stretch what's ever limiting them, causing them knee pain, so that you alleviate their symptoms. At that point, it becomes symptom-based. If it's a 10-year-old that's doing it, then what do you work on? Then you work on the pelvis. That's correctable at that point. Yep.
Didn't you say though that like in class, somebody that has super tight hamstrings, like it's probably not going to get any better when they're old?
You don't lengthen the hamstring, but you can increase the extensibility of the muscle. That's why people have to chronically stretch their hamstrings. Every day, people with tight hamstrings should be stretching, and that helps them throughout the day. Does it actually lengthen it? No. Tendon doesn't really stretch. If you really heavily work on it, you may get some sustained improvement, but I've never seen it happen.
Do you find, this is kind of going a little bit laterally here, but do you find if you treat other parts of the kinetic chain that you can elicit changes kind of more in the hamstring as well? So you might not just, if they got hamstring issues, okay, but let's see what we can elicit with sacrospinalis or anything up the kind of mid upper
And
back
again,
line there.
anything, that's why I said you're looking above and below at the effect. So you can address above and below. Top-down, bottom-up treatment is very common. So if you're looking at lumbar pain, more passive approaches are things like table exercises and modalities. But when you go more dynamically with, has anybody heard of Gary Gray?
Yes.
Some. He's a therapist that was a big advocate of kinetic chain motion, where you're using stuff like your arms to trigger responses down the chain. So it would be top down to the lumbar spine, or the legs bottom up to trigger the lumbar spine.
I know a lot of people look at like the subsystems of the body for gait and stuff, you know, anterior and posterior oblique slings, and we'll start to correct gait mechanics through those systems as well.
To do that, you need in-depth analysis, which most of you will never have. Clinics don't have it, unless you're working in a university environment, a training environment like you were in over the break, if they were deciding to do something like that. But then it's more academic. You're not going to bring somebody in and bill them for that. It's just not fiscally feasible. Posteriorly tilted pelvis, iliopsoas pulled on, again tighter or lengthened, potential to limit posterior femoral excursion. So if the psoas is tight and you're not getting enough push off when you progress forward, so you're cutting your step short, that can elicit pain. Does everybody see that? And can picture that in their heads, how the psoas or the hamstrings are pulled on and can limit motion.
I can picture it, but why does it cause the pain? Is that because you're not getting that full...
Oh, if you're changing it, if it's unilateral, you'll create a torsion in the pelvis, which we'll get to when we cover sacrum. but any change in the gait pattern changes that distribution of force up the chain from that ground reaction force. So look at proximal femur to assess for possible rotation. Greater trochanter may sit anterior or posterior, indicating a torsion, which we'll go over what those do. But that's looking at the side. Here's your greater trochanter. Is it sitting way up here, or is it sitting way back here? That can indicate a torsion. Which, in a kid, it's viable to send them to a reconstruction specialist to determine if surgery is appropriate. But if it's teenager or beyond, I wouldn't even bother. They're not going to operate. It's a massive, massive surgery to correct that in terms of sawing the femur in half, rotating it, pinning it back in place, and then immobilizing them. In a little kid, you can do it. Adults, it's not worth the hassle. Look at the distal femur. See the profile of the patella. But remember, the patella sits in the lateral, not the lateral groove, it sits in the femoral groove. But if you are seeing the patella sit laterally, what does that imply about the groove?
Sorry, say that again?
If the patella sits in the femoral groove and you're looking at the distal femur and you see the patellas pointing out to the side, which means it's lateral, where's the groove? Lateral, which means you could be rotated in terms of the femur itself rotated, or the person is standing toed out, and you keep going down the chain. Too much patella, femoral retroversion. Too little patella, femoral anteversion. So there's your versions. So normal hip, right here. We see the angulation comes right through. Generally, when you look at that, you're looking through the second toe, right through the trochanter. But in anteversion, the ball of the proximal femur and the trochanter in alignment, but the femur is turned inward. Okay? What might someone do to compensate for that? Toe out. And this is from, you don't develop this at like 20. You don't just start developing this type of angle. This is from birth. So as the kid's developing, are they going to walk around like this? Or are they going to naturally start trying to turn their feet out? They naturally turn their feet out, which generally creates pronation at the foot, external rotation of the tibia, and you get compensatory tibial external rotation to turn this foot back out. Retroversion, you're turned out naturally, and you would get compensatory anteversion of the tibia to turn the foot back in.
Is there always that writing pattern?
Not necessarily, but it's very common to see it.
So
It could be just the anteversion, retroversion, but very often when it's from birth, you will see compensation. And then the trick is to determine which is actually the original source, because if they pronate themselves enough to turn the tibia back out, the tibia actually torsions. Because they're little and still developing, they actually force it to turn out. So now you've got a retroversion, anteversion in both the tibia and the femur.
So what if you have someone who is, in their early 20s, but they're overweight and they have hip, knee, joint problems, but they have the toe out? Is that not a deformity? That's more like a...
That's probably not a deformity. That's probably them compensating for the overload and the mass that they're carrying, and or they're pronated naturally.
Okay.
When you say overweight, are we talking
Like
gigantic?
No, just like significantly overweight. But it's hard to tell, like, when you've been growing up, you don't know like what that is. You're not sure like if it's because they've accumulated weight over time, or if it's been something that...
At that point, usually when it's, say they have ankle, knee, and hip pain, number one, the weight's probably the issue. That's a big component of it. Number two, muscle deconditioning, so muscle imbalance. So you sort of triage what you can treat. As a physical therapist, are you going to treat the alignment? No. That's not going to happen. You are going to treat around the alignment. You're going to work on muscle strength, promote weight loss, and try and balance things out. When that doesn't work, if it doesn't work, Then you look at diagnostics at the hip, knee, and ankle to determine actual joint issues. Usually what you can do in that case is just a simple set of standing x-rays. And x-rays, the machine actually goes around you. UB has one. I don't know if Excelsior has one. You're standing there and they measure everything. So the x-ray actually comes out as a long sheet that is your height. So it spits it out of the machine and you can take a ruler and start measuring things. And that's how you do that. I had to do that actually for an engineering class for orthopedics. We had to measure x-rays. It was really old school, and we had protractors and did angles and stuff. The computer does it for you now. You just point and click and it determines all those angles.
Get out your slide rule.
We had slide rules.
Wow.
Yeah. Well, the guy who taught it was like 90, Frank Medich. He's still there. He still comes in. The guy's, I don't know, God, he's been at UB since the 50s. Which means his pay rate is like the highest on campus. He makes a little less than the president.
Just a little.
All right, antiversion, vertical ground reaction, force, point of application at the foot will shift, right? So if we're antiverted, we're turned in, we're going to shift where that force is coming through the foot. We're going to get abnormal responses up the kinetic chain and abnormal muscle activation. Retroversion, same as the above, but greater stress anterior hip. Does that make sense? So if we're turned out, that femoral head is going to be pushing more on the anterior structures. If we're turned in theory, it's going to be pushing more on the posterior structures. So lateral view of the knee joint, again, too much or too little patella. Tibial torsion, internal or external rotation. We can see influences at the knee. External torsion or external rotation is a valgus load. Internal rotation is a varus load. So with external, we see pes planus, which is pronation, right? Did you learn that with Dr. White? Okay. And pes cavus is the internal presentation, which is a supinated foot. So rotational deformities, external tibial torsion, internal tibial torsion. Again, when you're looking at this, you're trying to identify the problem and then determining what effect you can enact above, below, or at the level of the deformity from a muscular standpoint. Since they don't let you play with sharp things, you're not going to go in and cut it apart and try and straighten it out. At the foot, you're looking for decreased functional range of motion. How do we do front? Did you cover functional range? How do we do dorsiflexion, plantar flexion, goniometry? Where do you put the patient? Come on, you did this.
Other foot drops.
So their foot, they're sitting up on the plinth, supine, pull the foot back, step on the gas, and dorsiflexion, plantar flexion. What's functional range of motion?
Just like when they're actually like weight loaded.
So you can take the goniometer, kneel down on the floor, and have them take a step as far as they can, or do one of these, and measure their actual tolerated dorsiflexion with weight. You look at that. Look at diminished forefoot flexion extension. That's a bit harder to do. The foot is, and you'll see when we cover the foot, you remember it as being triplanar, right? Three motions in one, and all the little joints are interacting and so on. The exercises are all the same, okay? Regardless of what level you're at in the foot, the treatments greatly overlap. And I've never been a huge proponent of breaking the foot down into segments. I've never seen the value in it. You can talk about it biomechanically, clinically, but the pragmatic application just is not there. And even when you get into detailed reconstructions, lateral joint, medial joint reconstructions, it doesn't play a role. You're still working on strengthening, range of motion, and inflammation control. It always points to the same thing in the foot. So I don't tend to nitpick the triplanar motions beyond knowing them in general. So when you see the foot deformities, you'll kind of know it. You'll say, well, there's something wrong there. You're not quite sure what it is because it's so hard to tease apart forefoot, midfoot, hindfoot. So frontal plane, So you're looking at the person from the top down or bottom up. Trunk, we look at medial lateral shift. What happens with, you didn't do ortho yet. Do you know what a lumbar shift is? With a disc herniation?
Oh, that's where they're leaning away from it?
You lean away from the side of the herniation, which makes them feel better. So these folks usually present like this. They're side glided to the side and they're sitting there and they can't straighten out. So that's an indication for spine pathology. Leg length discrepancy, which can occur with unilateral inanimate rotation. You know what the inanimates are? Is that word used?
To, you know,
Half the
bilateral
pelvis.
collateral joints, yeah.
And or scoliosis. So pelvis, when you look at the pelvis, look for hiking, one side above the other, or when you say one is high, you could actually be indirectly saying the other side is low. I've always gone with the side of pain is the pathologic side. So if it hurts on the left and the left side is lower than the right, it's left is low versus right. If it hurts on the right and the right is above the left, its right side is high versus left. That's how I define it. So leg length can be easily assessed. You probably learned the supine to sit. Or I just do the malleoli, medial malleoli together with a pull and see where they line up. Anterior rotation of an inanimate makes the leg longer. Does everyone visualize that appropriately? Okay, because the acetabulum is offset. So when it's tipped forward, the leg gets pushed down, and when it's posteriorly rotated, it pulls the leg back up. So femur and tibia, rotational torsions from the prior slide, patellar position, medial or lateral. A medially situated patella can be due to anteversion and compensatory retroversion of the tibia. Lateral may be due to retroversion of the femur and anteversion of the tibia, so it could be vice versa. Don't confuse osteoarthritic varus valgus. Okay, so if the person is 20 and has this abnormal patellar positioning, that's one thing. If the person's 70 and has it, most likely what has happened is the internal knee has eroded and they've fallen into a compensatory rotation at the joint. The femur and tibia are normal. They've just fallen into valgus. So there you go. There's your normal. There's your varus. If we're looking at varus, which side of the joint has eroded?
Medial side.
Medial side. And valgus?
Lateral side.
Lateral side. Very often, though, when you look at these patients, you will see an underlying anteversion, retroversion that has gone undiagnosed, or it's diagnosed and there's no treatment for it, and eventually they erode the knee joint. Yep.
So, I assume that erosion is going to cause them knee pain, right?
Yeah.
So,
Oh, not necessarily.
So-
You'd be surprised how many deformed people don't hurt.
okay. Because I was going to say, if they had a varus and it was causing them pain, would they just go into valgus to compensate? Like, would they shy away from the
Oh,
varus
naturally,
position?
like the person doing it?
Yeah.
Yep. That can happen, or you have unloader braces. He's here now. He was one of my advisors at UB. He's in their online program teaching. He's a biomechanist, Dr. Ramsey. Did a lot of work with knee unloader braces in Sweden and did some papers here in the U.S. on it. Europe is big on conservative treatment, and they do things like if you have this type of arthritic deformity or this type of arthritic deformity, you can put a brace on that pushes you in the opposite direction, so you unweight the irritated area. That, in almost all cases, except obesity, that alleviates all the pain. You can function, you can walk, you can jog, you can do all sorts of stuff. It never caught on here. Why?
People think braces are like a crutch.
No.
People want a quick
Braces are
fix.
much cheaper than doing other things, aren't they?
Well, who serves to lose for that?
Orthopedic surgeons.
The surgeons, the insurances, the healthcare providers, it all feeds back into a money environment. And actually we had commentary from a very prominent, nationally renowned surgeon who liked one of the papers that came out of our lab, but said it'll never catch on because orthopedics is a money-driven entity. that people come in, this shows up on the x-ray, surgeon says, I can fix that, let's fix it. Okay, that's a knee replacement on the schedule. Instead of getting fitted for a customized brace that could alleviate all the pain when they're being functional. You have to decide what's right for you. Yep.
Well, I mean, they exist though, so can't you get them?
You would know about it, but if you had no orthopedic background, you were an accountant that never got hurt in their life and went to the orthopedist and they said, well, we can operate on you. You'll say, okay, I trust you.
So, do we have these in the States?
Sure.
To get customized
Yeah,
and everything?
they're all over.
Oh.
Just about to buy
I
a
think
pair.
It's just very rarely that they're prescribed.
Well, is it a permanent fix, or do they have to wear the brace always?
Dynamically, they have to wear the brace. So if it's somebody who wants to go golfing and they have pain when they golf because when they twist, they shear that joint, that brace can alleviate that.
Oh, so they don't have to wear that all the time, it's just when they're...
They may.
Oh.
It depends on the level of arthritic change and the pain. Obviously, if it's somebody has to put it on in the morning and wear it till they go to bed, that becomes a bit of a hassle. But some people are absolutely deathly afraid of surgery.
Right.
They will not go near a hospital. They're afraid of doctors. They're afraid of you. They're not you personally, but they're afraid of seeing anybody in the medical field. And that becomes something that, well, you come up with another source to treat them. But it comes down to patient preference and money. Mostly money. So foot can be sagittal or frontal plane view. Look for the pes planus, pes cavus. Again, planus is over pronation, cavus is supination. You do have a certain degree of pronation and supination that's natural. We have a computerized thing in our office that does foot screening. It's a pressure mapping thing that person puts their foot on, it maps it and creates the orthotic that we send to that profile to a lab in California, and they send us back the customized orthotic. Speaking of money, the same exact system is used around Western New York by podiatrists at a rate of about $400 to $600 per set of customized orthotics. We charge $125.
At UB.
No, at South Towns PT.
Oh, neat.
The lab recommends we charge $500. We don't charge $500. We make like $10, $20 on each pair, and that's it. And that's the cost of us shipping it out, getting it back, and the time it takes, which it takes like 10 minutes to do the screening. But the podiatrists say, oh no, this is highly custom. No, it's not. It's the same thing we do in our office.
Do you just call out like surgeons? Like if they're trying to like give you like a rundown, do you just be like, no, that's not right. That's not right.
What do you mean?
Like
Me
if you have to go,
personally?
yeah, like if
Or
you have to go in for like a surgery.
me personally going in?
Yeah, you.
Oh, they don't question me. I usually get, what do you want now? If it's patients, I subtly suggest that they see someone else. And I've done that a lot. You know, you might want to seek a second opinion. I always tell people to get another opinion for surgical treatment. And then, oh, okay, who would you recommend? And I get them in with the other person, and almost always they go with the recommendation I give them. I've seen a lot of bad outcomes. And the surgeons, you know, they shrug. I've seen people who have had 3-4 revisions on shoulder, botched shoulder stabilizations. It's a disaster. The one guy left, what was his name? Heyman was his name. He's now in Arizona. And I saw multiple patients from him, and he kept screwing up their shoulder stabilizations for chronic dislocations. And he would do, they don't do it anymore. It's actually in the shoulder paper I posted. Did I tell you there's a shoulder paper on instability?
No.
I did not.
I didn't in lecture?
No.
I swear I did. Well, I'll mention it again. Anterior stabilizations are fairly common. Most 3rd, 4th year residents could do it. It's not a hard procedure. He botched it. And the person within, the one girl, it's a younger girl, probably in your age range, and she came here, and I remember that. She was a Duval student, not PT. She was a cheerleader and in high school, and she was the person on the bottom, whatever that is, holding somebody up, and she popped out the front. And it kept happening. So he went in and did a stabilization with a thermal capsulorrhaphy, which is using thermal probe to shrink the collagen in the capsule. They now no longer do that. It doesn't work. But everyone was doing it at this point. This was around 03, 04, 05, somewhere around there. And within 2 weeks, she popped back out again. So we went in and did it again. Same procedure. She popped back out again. And then he went in and tried to do a traditional Bankart repair, which he should have done in the first place. Tried to do it arthroscopically. Didn't get enough capsule in the repair, which you saw some of that when the cadaver repair. He tried doing that, but from the inside out with the scope. That failed. So that was how many? 4? Three. She then had a Magnuson stack, which is, nobody does this anymore. It's where you take the subscapularis off the, is it the lesser tubercle that it attaches? Cut that off and pull it over to the greater tubercle. So that dynamically any external rotation tightens the subscapularis on the front of the joint so the humeral head won't pop out. It was done back in the 50s and 60s, and this guy did this. She was cut up, mangled, mashed, and a mess.
At that point, why do you still keep going to the same guy?
Yeah.
You don't know any better.
What?
You don't know any better.
But like, yeah,
I think you would after your third one.
Patients become endeared to their practitioners. The doctor's nice, shakes their hand, smiles, is kind, listens. They're doing that so they don't get sued. Okay, that is, I'm not making this up. This is very, very clear. Patients don't know any better. And
Did you tell her?
oh, I didn't see her till the last surgery.
Oh, okay.
I got this in her history.
Oh.
And I saw her for the last surgery, which actually she was okay and said, I'm not having any more surgery. I was like, okay, good.
God.
So she was okay after that subscapularis pull?
She didn't pop out anymore, but she wasn't doing anything physically. She had no range of motion. I mean, she could do this. She could do
Would
this.
you rather pop out than not?
Yeah, seriously.
What is this?
I mean, that, they'll call that a success. Success, yeah. You know what I mean?
Yeah. Win.
What was another one? I mean, my hips failed, but they failed 3 years after the fact. No rhyme or reason as to why. That type of failure is different than if it had failed a month after surgery. That means something was done wrong in the surgery. But 3 years, you know, I had abnormal bone growth, I had heterotrophic ossification, things changed. That type of thing where you're popping out a week after surgery, that's bad. Okay, that's grounds to run from that surgeon. So keep that in mind, and one of the things is you want to learn who does what and what an individual's outcomes are.
So do you think that people being able to walk off the street, like, and see a PT now, and like having them diagnosed?
Yeah, but
I think that's gonna
I
hurt.
see about 2 or 3 direct access patients a year. We don't advertise it, we don't do anything with it, and if any one clinic decides to advertise, then all the other clinics get on their, it's like a lunchroom in sophomore year in high school with these owners. It's
So there's not
ridiculous.
many people doing that.
Oh, they do it, nobody advertises it. I saw the one clinic was, what's that guy's name? He's on Harlem,
I'm saying no one comes in like off
off the street,
yeah.
not unless they're former patients.
Okay.
They don't just like say, you know, my back's hurting today and pull into a therapy clinic, not like they do a chiropractor. It's just well known that you do that with a chiropractor, but not physical therapy. It's not promoted.
I promote it.
We'll be the
Good.
change,
Yeah.
guys.
Yeah.
We'll be the
Send all my
change.
patients.
You can, that's good.
So why do other clinics shoot it down when a specific clinic does it?
Well, it's not so much that they shoot it down, it's almost like, who do you think you are? You're promoting your clinic, but you have to understand the dynamic locally. All the private practice owners are in a group. It's called the Western New York Owners Something Society, I don't know. There's probably a secret handshake and everything. I used to go to some of the meetings and I got fed up with it because it's a lot of griping and it's a lot of complaining, and I'm not an owner, so I had enough of it. Did I complain about photo in this class?
Photo?
Do you know what photo is?
Is that like the survey thing?
It's an outcome tool on the computer.
I read an article the other day where having like survey based on a service is like a kid filling out a survey on why they don't like school.
It is. The problem is photo is computer generated and it's a smart program. So the answer to question 1 determines what question 2 is. The answer to 2 determines 3 and down the line. The problem is when you go through the questions, you get like 85-year-olds and one of the question is, can you run 100 yards? And that's my gripe with it. And nobody listens to me. I don't. Hopefully some of you listen and we'll at least get it right on the tests. But nobody listened. I said from day one that this was a flawed program. They farted around with it for 5 years. All the owners dropped the program. Nothing came out of it other than they wanted to get data to take to the insurance companies to say, look what physical therapy can do. Insurance companies say, that's nice. What do you want us to do? Give us more money. No. That's the answer. There is no more money to give. And if the insurances give therapy $5 more per visit because of photo, who's going to get mad at that?
Patients?
No.
Insurance companies?
No. Who holds a whole lot of power?
OTs.
No. Physicians. Physicians have all the money, all the power. The physician group goes in and says, you just gave them $5 more per visit. Where's ours? Nobody gets more money. Was that a stretch or a?
I was stretching.
Okay.
Yeah.
Is there a place you can go to look at surgeons' outcomes and like find out if they suck?
Not really.
Let's make
Observational.
Locally, you can ask me.
All right.
I've been to plenty of them. I haven't had any
I feel
screw
like-
ups.
I feel like that should be public.
Public
If you
knowledge.
like Google a surgeon, they have like a rating on them.
Yeah, but a lot of that's anything online. You got to remember, there's a website online that only gives me like a 2 out of 5, and it's based on 2 surveys, and we know who it was, and it wasn't even anybody that made it back to me. It's somebody who had a problem with the front office, where I used to work in Clarence.
That's awesome.
Where'd
You
you work
had-
in Clarence?
Ken Kurtz, physical therapist. You have to be careful with the stuff online. Because a lot of surgeons don't promote themselves that way, and those are some of the best ones. Was there another hand up? Now that we've gotten off a topic and turned into a money griping fest. All right, so we're looking at dynamic running, walking, which you can do. It's a bit more efficient to look at running on a treadmill, but is treadmill gait the same as
No.
land gait? No. That's another gripe I have with one particular physical therapy practice. They promote themselves as running biomechanists. And they have this thing that you take video on the treadmill and you pay and they give you your biomechanical analysis. It's all on the treadmill. So unless you're running on the treadmill all the time, it's worthless. And they have side startup, like online things that you can pay with PayPal and all this stuff. No thanks. Some deviations are adaptations to heavier loads, such as running, so you won't see the problem in walking, you'll only see it in running. So you may need to get them on the treadmill just to pick up the idea of what's going on. And there's your nice foot alignment going up the chain. For a while, this was really big in physical therapy, sort of flavor of the week with some of the physiatrists, which are physical med and rehab doctors. They're essentially glorified physical therapists. They can do injections, and they have a prescription pad. They can write prescriptions for meds. Everything from about 2002 to 2006 was due to foot alignment. If you had knee pain and went to these people, they said your feet were bad. Pelvis, SI, low back pain, they said your feet were bad. And would make custom orthotics and bill $500-600 for them. It wasn't that. Usually it was muscle imbalances and just needing to condition. But orthotics do a tremendous job when there is a foot abnormality at correcting everything up the chain. You've all bought new sneakers, right? And you see how nice and cushiony they are when you first put them on, and you feel different when you're walking, running, etc. Same type of thing with an orthotic. All right, so male versus female, one shoe on, one shoe off. Identify pronation, supinating. Should anybody pronate here?
We'll find out.
Oh, we don't have time to do all of you.
I think I'm like naturally pigeon-toed.
Okay, well, you're the example since you were late. You'll be our female. Who wants to be male? Which male wants to go?
Casper, go. I'll do it.
Casper's doing it?
Oh, Casper decided.
What shoe do you want off? Doesn't matter.
First, let's do the board. Somebody grab the other end.
Oh, yawning, Sam.
I wasn't all that hungry, but I fucking need to eat something. Yeah.
All right, so you're all facing that way. I'll face this way. So you're looking in what plane at them? Sagittal. So let's do Jessica first. You said you're toed in? Okay, so pop your boots off.
Both of them?
Yes, please. Now, in theory, when you're doing this, the person should be in shorts, yes? So you can see everything. I've never been a stickler clinically for this, so patients don't have shorts. I just work with what's there. So let's see you walk back and forth. Take your jacket off, too. So you're going to have the person walk in, you do toe in. Keep going back and forth. So any deformities that are obvious at the pelvis? Well, actually, let's start at the head. Is the head in the right position?
Yeah.
Trunk? Keep going.
Pretty good, yeah.
Any trunk deviations?
She's got like no T-spine rotation when she's walking.
It could just because we're all staring at her. I've noticed that as an issue sometimes with students. Keep on. Okay, anything in the pelvis from sagittal, anterior posterior rotation that looks abnormal? No. Okay, how about the femur? Does it look like it's moving appropriately? Yes, no?
Yeah.
Tibia looks okay, we can't see her patellas. And how about the feet?
Looks like they're toned in a little.
But look, only from the sagittal plane.
Oh, yeah. No, nothing.
You can't really see anything sagittal plane. Okay, now let's have you walk from front to back this way. Can you all, come on down to the next aisle way. There you go. That way everybody can kind of see. Again, head, right position, shoulders, right position. Is one shoulder up or down?
No.
Okay. One shoulder up could be scoliosis. Does the trunk look square? Okay. Pelvis looks somewhat even. Again, with shorts on, you can have the person lift their shirt up and you can see their iliac crest going side to side. Any deviation in the femurs?
Is she internally rotated?
Well, you're looking at the feet. Just look at the femur. You would see it possibly based on where the patellas are. Can you pull your pants up over your kneecaps? Proper lab attire. Do you have shorts?
No, I don't.
Nobody has that short.
Proper lab attire. If everyone else jumps off a bridge,
She jumping too.
I can save them all.
are her kneecaps turned in, turned out from what we can see?
Right one kind of was turned in a little.
Okay, and definitely the feet are turned in.
How do I do that?
You screwed up.
It's hurting
Yes. All right, and the feet, are they pronated, supinated?
I feel like they're pretty good.
Do you mind popping your socks off? Okay. Functionally, she's pretty flat-footed, actually. So who said supinated? You're wrong.
Okay. Oh. Whoa.
And she's turned in. So where would we go from there with this? That's your analysis. Everything's normal except for something going on at the ankle-foot complex turned in, which could be femoral, could be tibial. Where would we go from there? Could look at the pelvis. What about doing an assessment of it? Leg length. You could look at those structures.
I think I do have a leg.
Go ahead and pop your socks and boots back on. Do you have sneakers? No. You could look at leg length discrepancy. You could look at what's the other one at the knee. What's that angle you can measure? Alignment of the tibial tubercle through the patella up to the ASI Q angle, which looks at the angulation there where you can see other problems. So when you do the week after next lab, you will be doing gait analyses with the different scenarios and groups, and each group will turn in a lab report. But it'll have to be a thorough gait analysis from the top down and the bottom up, and if there's nothing there, you still have to represent it and talk about it. Now let's do, one boot. I'm sorry, leave one off. Okay, so in this scenario, which leg is longer? Right leg. By quite a bit, so let's have you walk forward or backward. And look at the deviation. So you see she's pistoning up and down.
How does this help?
How does what help?
How does doing this help? Like this is like a.
It doesn't help anything. We're just representing you as a deformed patient.
Oh, okay. I didn't get what was happening.
So her right leg is long. You can see she's pistoning. And what's that going to do to the step on the left? If the right leg is longer, will she have the same length of step? No, because it's longer, it's going to contact the ground sooner.
The right leg's going to contact the ground sooner?
Either one will. Usually it's a compensation. She won't do it naturally because she's not naturally leg length discrepancy, so it's hard to see. From your view, sagittally, what do you see on the pelvis? I notice it right away from the sagittal plane.
Oh, from the sagittal.
What's she doing? Keep that speed going. There we go. I see it right away on the right half of the pelvis, sagittal plane. She's tipping back further, so she's anteriorly rotating to compensate for that leg length discrepancy. So she's trying to anteriorly rotate as she extends, and I see the rear end on the right side come back further. Okay, now forward, backward. See the difference? So you can see the frontal plane pelvis is wobbling side to side. You can see a shoulder discrepancy. You can see she's pistoning more up and down. All right, that's enough picking on you. Casper's turn.
Oh, look at this
Nice
kid.
shorts.
Nice socks, nice shorts. Can you hike them up? There you go. That's better.
I do have little legs. I am small.
Now, contrary to Jessica, Casper is what?
Yeah.
He's more turned down from my perspective, but from your perspective, he's fairly neutral. Head, trunk, pelvis all seem neutral, would you say? Okay. Can you see the patella in the sagittal plane, or does it look fairly neutral?
I'd hope you could see it in the sagittal plane. I'd be concerned.
Kind of rotates out and rotates back in.
Yeah.
Mhm.
So you can see a little bit.
Well, part of that, he's out, in. Now, I see why he's doing that in this plane. Let's go back and forth. Keep your pants up. Do you see the patella coming out and rolling back in?
Yeah.
Yeah.
Okay. What's he doing when it turns out?
Turned out his dorsiflexion.
Look at the foot. He's in what phase when the patella is turning out? So just look at the right leg.
Oh,
First one.
Turn out, in, out, in. Keep going. When he's taking his step, he's turning
Oh,
out
yeah.
and then back in. So he's doing what by externally rotating? What's he preventing?
Toe from striking the ground, maybe?
Say it.
The toes from hitting the ground?
Mhm. So that's a compensation. He's almost circumducting. His hips aren't doing it, but his tibias are. He's got a little rotation at the hip. So he's clearing his foot by turning out, bringing it around, and then when his heel strikes, his knee goes back to center. So is that efficient? Inefficient?
It's still walks, so it's kind of.
Walking, yes, but if he's running,
No.
no, that's an inefficient pattern, and he would have breakdown. Do you run?
I used to.
Past tense?
Yes. Very much
We're all washed up.
I'm washed up. You're hardly washed up. When you hit 11
You're prime.
surgeries, you're washed up.
Wasn't that Jack's
couple
No, does that make sense?
6:30.
Now put a shoe back on. Let's see what he looks like. So next time, I'll call it up before you leave to make sure. I think we want women bringing in heels.
I don't know those.
Does anyone? All we needed really is one. Okay, one or
Ellie's
two.
got it right.
Yeah, you want me to bring yours in, or the ones left
I feel
over?
like I'm not with
I actually had a 91-year-old,
I know for sure.
what's today? Friday. And she's wearing winter boots that had a heel this big on it, and she's wobbly. And I tried telling her you needed something flat, and she said, "Dear, I don't have anything like that."
Oh my
And I
God.
said, "You don't own sneakers?" "No, dear, I don't like them." "Ladies do not wear sneakers."
Oh, Jesus.
"Okay."
Old school.
Yeah, but
Probably can't.
30s. Yeah, go ahead. So I still see, well, you'll look at it when you see them that way. What do you see from the side? Any change?
He's still pistoning a little bit like she was, like up and down, like you said.
I also
His
don't-
leg length difference though is less than Jessica's. Her heel was
Yeah, her
bigger.
heel is
I
bigger.
don't have that. I don't have the crazy boot heels.
I like your socks.
Thanks. I got them from Yellowstone.
Yeah, his feet are kind of big.
Your feet are bigger than your butt is.
All right. Thanks.
You're welcome.
It makes me
That's why you have to
efficient
turn it
at
out, otherwise
swimming.
you'd hit him.
His feet are bigger than what?
I feel like they're too big for his body.
You should do something about that, Casper.
Yeah.
Travel. You could do some bending.
Does the one leg length difference affect the turning in, turning out?
Yeah.
Look on the right knee and the left knee. It was symmetric.
The right's not as bad with the sneaker on.
Why do you think that is?
For
I still see the turning out at the
Yeah, I
foot.
definitely see that.
You said
Why do you, what was your question? Why do you think that the turning out's less on the right knee now?
Yep, somebody said the sneaker side is not as pronounced.
Okay.
I think his right shoulder looks just touch over there as well.
He's contacting the ground sooner, so the pattern has to occur quicker to clear the foot.
Good
job, Jack.
Trap sizes.
Let me guess.
Makes sense. I don't know when you came up with it.
Good. All right, does that make sense?
Yeah.
So we'll work through these when we do. We'll be on the treadmill as well. We'll look at some running gait, walking gait, with and without heels, leg length discrepancy.
Where are junkie heels?
I think that's it.
For running with their heels on the treadmill?
Do you have to be like
No.
woman?
As long as it's heel,
Okay.
because you're gonna also draw some ground reaction force diagrams for this.
Okay. Do we figure out when those are due?
What, the lab? I didn't tell you?
The,
No, not
They're
already.
around spring break.
No, first week of March. So
Oh,
that
she's
lab week, you turn them in.
He meant to say
Okay.
our
And then,
students.
when are your office hours?
What do you mean all of them?
All the labs?
No, the free body diet.
When are your office hours?
Oh, first week of March?
Yeah.
Okay. Just checking. I heard like half.
When are your office hours?
Today till 2, after this next lab, tomorrow, I'll be here longer, Thursday for a bit as well, because I don't
So
have
then,
my
like,
shirt
next-
lecture.
Wait,
You've got like 2.5 weeks.
okay.
You want to put a nice
We'll wait till after this first round of
So
tests.
then next Wednesday, you
First
do the
round.
same office hours as you are
Tomorrow.
Possibly. Yeah, I gotta
Tomorrow I'll be
do
here
one thing
longer
for-
because there's no
pick a class
faculty,
in
there's
car
no
that's
faculty on it.
Yeah.
I'm the big man on campus for the week.
Okay.
Only for the weekend.
I'm gonna make decisions and sign checks and,
Yeah, right.
it's like the Catalina wine mixer.
I'll find the checks. I'm the boss.
No one got my Step Brothers reference? I got it, okay. Catalina wine mixer.